Thanks. Pleasure to be here. I know none of you see IBS patients in your clinic. I'm always intrigued to hear the hepatologists talk because they're curing hepatitis. I think we need to hurry up and try to do that here, or I need to send all my IBS patients to hepatologists. Let's start. The whole purpose of this talk is IBS and the gut microbiome. That was what I was asked to present, and the update from DDW. And so what I like to do with these post-DDWs is to sprinkle the abstracts around what we're trying to learn in IBS, but argue as I go through this that maybe we know more about the pathophysiology of IBS than we do of IBD now in 2018. So maybe you'll want to listen to that, because we're working around this framework here that food poisoning triggers IBS, and there's a sequence of events which I'm going to walk you through, and data that continue to accumulate even at this DDW to suggest that this sequence of events may be what's causing IBS, and that there is a dysbiosis that develops as a result even of autoimmunity. But we're going to focus first on the right-hand side, and that's where it all starts, is are there excessive bacteria or is there a dysbiosis in IBS? And we know that the notion of bacteria in the gut is very complex. A lot of what has been done in the last 10 years since the Nature paper of the gut microbiome, the human gut microbiome. The problem with the human gut microbiome project is the human gut microbiome project is not the human gut microbiome project. The human gut microbiome project is the human stool project, because they never looked at the small bowel. So they have no idea. And in fact, as we now know, based on data that are emerging, the colon of a human, the microbiological composition of the colon of the human is more similar to the composition of a stool of a mouse than the composition of the stool of a human is to your own small bowel. So the composition in the small bowel is radically different, and you're going to see a series of papers emerging over the course of the next year that demonstrate that the small bowel is completely different. So that is what I should say is that the human microbiome project for the gut is not complete, and the small bowel is the next sort of area. But the large intestine contains the majority of the quantity of bacteria because it's a stagnant organ. It takes 24 hours for things to pass through at a minimum, and as a result, bacteria have a lot of chance to sort of live there. The small bowel is a faster moving organ. There's lots of fluid flowing through, and so bacteria have a harder time hanging on, and as a result, you can imagine there's more oxygen, there's more things. Therefore, the bacteria are different. But the composition of the flora are different, and the quantity are different, as I mentioned. So 10 to the 3 is now the new standard for what is normal in the small intestine based on the North American consensus cited here. People get very confused when this term small intestinal bacterial overgrowth comes into play, because they say, well, is it IBS or is it small intestinal bacterial overgrowth? Should we do a breath test? Is it a breath test positive patient? Are we giving antibiotics because it's overgrowth, or are we giving antibiotics for IBS? And it's all confused. But it's not confusing. SIBO, small intestinal bacterial overgrowth, is not a diagnosis. Small intestinal bacterial overgrowth is caused by something. Stasis. It could be adhesions. It could be diabetes with enteropathy. It could be scleroderma with pseudoobstruction. All of those things cause bacterial overgrowth. And in IBS, a subset of IBS patients have bacterial overgrowth, we believe, due to a neuropathy of the gut. The cause of this neuropathy remains to be known, but I'll point to some data that may explain some of this. So it's a Venn diagram, and I want you to think of it that way. Overgrowth can be caused by a lot of things also, and IBS may encompass the bulk of it because IBS is such a prevalent condition. But as we're starting to understand the microbiological subtypes of IBS, we're starting to think of IBS in sort of 2 frameworks rather than 3. Here's the framework we've had all along: IBS-D, IBS-M, IBS-C. Why did we do this? Well, we did this because for IBS-D, we have Imodium. For IBS-C, we have laxatives. For IBS-M, we're just sort of finding the middle, but we were able to stratify treatments based on the phenotype. But if you stratify treatments based on the phenotype, just constipation versus diarrhea, then all you're left with is treating the symptom rather than treating a cause. But as we're unfolding a cause, we think there's really 2 subtypes. There's the IBS-D and mixed, and then there's the constipation, because the microbiology is different of the 2. So breath testing, there was a lot of interest in breath testing at this meeting, in part because there's a new machine emerging that's studying the final gas in breath testing, which is hydrogen sulfide. So remember, a breath test revolves around ingesting a substrate, which then goes into your stomach, enters the small intestine, where it's fermented, and when it's fermented, the gases that are produced include carbon dioxide. Well, you can't use carbon dioxide because humans produce a tremendous amount. But you can use hydrogen and methane, which has been the standard for breath testing, and then these gases go to the lung and you expel it in the breath and we can detect it. This is an early meta-analysis. There's probably 3 times more studies than this now, but in this meta-analysis you can see that IBS patients test more commonly positive on breath testing to suggest an abnormal fermentation in the gut after lactulose, glucose, it doesn't matter the substrate, and the odds ratio is about 10. So IBS patients are fermenting in an abnormal way. We now know that a lot of this could be due to bacteria in the small bowel. This is a study from Sweden. 24% of patients with IBS had greater than 5,000 coliforms compared to a very low number this is 24% with greater than 10,000, and then much higher, 43% greater than 5,000. The point is coliforms are accumulating in the small bowel of IBS patients, and we now assume that that means overgrowth, but again, it's terminology. The bacteria are essentially accumulating for reasons we didn't understand. E. coli and Klebsiella, turns out these are the major players in this accumulation. Now, this doesn't look like much of a difference when you compare IBS to sick people who don't have IBS undergoing endoscopy and healthy, but these are log 10 numbers on the y-axis, and it's statistically significant for these 2 organisms. But how does that funnel down to gases? So the predominant gas that's produced that isn't CO2 in the gut is hydrogen. And Bacteroidetes, for example, produce hydrogen. E. coli produces hydrogen. Many organisms produce hydrogen, but the story is incomplete there because hydrogen is a fuel. Now, all the years that breath testing has been done, one of the arguments against breath testing is, well, hydrogen doesn't predict symptoms. And that's true. We've done breath tests on thousands of patients, culminated that data. It doesn't matter whether your hydrogen's 100 or your hydrogen's 40, both are positive based on consensus. 100 is not more sick than 40. So we could never correlate hydrogen to a particular symptom, and therefore it argues against breath testing as being important. But hydrogen is a fuel. So hydrogen is used by methane organisms to produce methane. But look at the stoichiometry. You use 5 hydrogens to produce 1 methane. So you're eating more hydrogen than you're producing methane. And therefore, it's like a vacuum. It's actually reducing hydrogen on a breath test if methane is present, which messes up your breath test. Hydrogen sulfide, or sulfate-reducing organisms, use 5 hydrogens to make 1 hydrogen sulfide, again, using up the gases. So when we do breath testing, we see positive methane, we see positive hydrogen, we see what we think is normal, and we see flatline breath tests where no gases are produced. Well, it turns out the flatline breath tests, you can't have no hydrogen because that's the most common organism, so the gas is being used to produce something else, but we couldn't measure that something else, which is hydrogen sulfide. So the breath test was always incomplete and an incomplete story. So it's sort of like this. And then if you imagine that you have methanogens eating hydrogen and hydrogen sulfide organisms eating hydrogen, that they're competing, they're fighting, they're trying to get this fuel because this produces fuel for them. And that's what happens. So this is a DDW abstract on this new device that measures all 3 gases. And what you see here are 3 curves. The first curve is no hydrogen-consuming gases. So this is just a native breath test. You don't find any methane, you don't find any hydrogen sulfide, and that's how much hydrogen is produced. But if you have 1 consuming gas, meaning hydrogen sulfide or methane, which is eating hydrogen, the hydrogen level is 56 parts per million lower, 106 parts per million lower if you have 2 consuming gases. I know this is complicated, but the breath test is complicated, and it's more complicated by this additional gas added. And that's why when you see the hydrogen levels, they never correlated with anything because the gas is being eaten by other organisms that we couldn't see because we didn't have hydrogen sulfide. More importantly, hydrogen sulfide correlates with diarrhea. For every part per million rise in hydrogen sulfide on the breath test, you get a 15-point rise in severity of diarrhea. So it's proportional. Methane is proportional to constipation. The higher the methane, the more constipated you are. So now that we have hydrogen sulfide, we have the missing piece of the puzzle. There are no other gases. We have the missing piece of the puzzle in terms of breath testing and why we would never see a correlation with hydrogen. We see the correlation with hydrogen sulfide, and that's missing. And that device is now fully validated through these 3 studies that were presented at DDW. But there's one more piece in that final abstract that was presented at DDW, and that is who wins. When you have hydrogen sulfide and you have methane, who's winning the battle in these so-called IBS patients? I want you to focus on the left because that's the lowest diarrhea score when you have methane. The highest diarrhea score is the far right when you have hydrogen sulfide. But if both gases are present on the breath test, methane wins. So methane is more strongly correlated with constipation even in the presence of hydrogen sulfide. Again, it means that you have to create an algorithm when you do these breath tests, and this is coming in the next few months. So, complicated, but what we do is we use antibiotics to treat IBS on the basis that there is a dysbiosis. And so rifaximin, a non-absorbed antibiotic, has been sort of the mainstay of therapy for IBS, but in part because it's reducing bacteria, but we now know that it's doing so in the small bowel because it doesn't change the fecal flora. Of course, this is the New England Journal of Medicine paper that summarizes the Target 1 and Target 2 trials. Rifaximin made abdominal pain better, bloating better, stool consistency better, the new FDA endpoint better, global better, and it did so on this next slide even 3 months after therapy had ceased. But what impact has rifaximin actually made in the community? But before that, let me talk about breath testing, because this was presented at ACG, and this is really important and something that's happened in the last year, is that there was a subset of patients in the Target 3 study that had breath testing. So I want to walk you through this abstract, which is going to be published very shortly, is that 44% of people responded to rifaximin in Target 3. That was the study without breath testing. Forget about breath testing, just everybody with IBS. They met that FDA endpoint. If the breath test at the beginning was negative, less people responded to rifaximin. If the breath test was positive, 56% of people responded with that very difficult FDA endpoint. But the most important column is the last one. If the breath test was positive and rifaximin made it negative, 76% of people got better using that very difficult FDA endpoint, suggesting that what we're seeing on the breath test is relevant to the impact of rifaximin and why rifaximin works in IBS. This is a very important slide because it summarizes a decade of rifaximin use, maybe, but over 10 years, all of us at tertiary care medical centers have been discussing that we're seeing less and less and less diarrhea IBS. In fact, this study shows that there's a 30% less D-IBS referral rate to places like Cedars at the same time as an increase in the use of rifaximin. But I want to point to the next slide because this is more interesting, is that despite multiple drugs being approved for C-IBS, we're seeing more C in our clinics than ever before. So it means that we need to do better in the C category. Continuing on with this whole microbiome and then adding diet to this is the first study, because we've been saying, oh, well, what we need to do is low FODMAP, what we need to do is low fiber, and people say, well, why would you do low fiber? That's good for you, but fiber makes fermentation. This is an interesting study that was at DDW, 15 volunteers, and they subsequently got high fiber, and then 80% of them developed digestive symptoms and changes in the microbiome that were adverse. So then, going back on normal diet, things regressed back to normal again. So fiber was bad for these patients. Now let's switch gears and go to methane. This is a meta-analysis of methane. Methane causes constipation. We now know that pretty consistently with all the trials. This is a meta-analysis from almost a decade ago. But here's another study. We keep showing more and more studies at DDW, 67 patients, IBS patients, 132 healthy controls. If you're C-IBS, your prevalence or your methane level is much higher than if you're D-IBS. But another study, the same study confirmed another finding with methane is that methane is associated with a greater body mass index. Now there's a lot of details to why this happens, but one of the explanations is that methane slows the gut down. There's more time for absorption. So theoretically speaking, if you're looking at the label of a box and it says 130 calories per serving, but you're a methane person, maybe it's 140, maybe it's 150, because you get more time to digest some of the non-digestibles and then liberate those calories using the bacteria in your gut. To treat methane, it's different. You can't use just rifaximin. You can't use just neomycin, and this double-blind study shows that neomycin plus rifaximin is superior to neomycin alone. This is a double-blind study we did in 2014. The problem with this approach is that 1 month after neomycin and rifaximin, the methane returns. So this is not a long-term solution. This is not like the Target 3 trial where things lasted for months and months using rifaximin for sort of the hydrogen side of things. So rifaximin and neomycin is not long-lasting, and so probably is not going to be a long-term solution. So we've been coming up with other solutions, and one of them is Lovastatin. Lovastatin, which is a statin produced by Aspergillus, when produced in its natural hydrophobic form, blocks methane synthesis by the methane producing enzyme F420 in these methanogens. And so there's already one study that shows in phase 2 that if you take this, A, your constipation's better and it doesn't cause diarrhea, and B, you use less laxatives, and that's the red line. The laxative use is the red line versus the other two arms, which are the medium dose and the placebo. Now let's focus on acute gastroenteritis because, again, there continues to be emerging data. But what I want to point out to you is this study from the Mayo Clinic from last year, which you may or may not have seen. This is a meta-analysis of all the acute gastroenteritis outbreaks to study the development of IBS. And 45 clinical trials, prospective outbreaks followed, 11% chance of developing IBS, 11% higher chance of developing IBS because you had gastroenteritis recently. So after this trial, we can say full stop. In 2018, we know a cause of irritable bowel syndrome because this meta-analysis is absolutely 100% clear: food poisoning, then IBS. And that speaks to my point that we now know more about the pinpoint cause of irritable bowel syndrome than we do about IBD. We don't know what triggers IBD, but we know what triggers a subset of IBS, and that is food poisoning. So this needs to be studied more, and we are. So look at the risk factors, though. It's mostly about how severe the event was. So if you had 7 days of diarrhea, that's worse if you had than if you had 1 day. If you have blood in the stool, you need antibiotics, you need to be admitted to hospital, you're more likely to develop IBS. All these organisms can cause irritable bowel syndrome, all of them, but they have only one thing in common and one toxin in common. And so for the last decade, various groups have been looking at the toxins to try to understand particularly this toxin. Us and a number of other groups around the world have been looking at CDTB, and I want to talk a little bit about this toxin, but it's the one that's common even in C. diff, because C. diff can also precipitate IBS. And through that work, it's been described that not having CDTB in the organism means you don't necessarily develop IBS in animal models. But the ultimate animal model is this one. You take the toxin, you inject it into the animal, do they develop IBS? And the answer is yes, they develop IBS. They develop antibodies to CDTB. They also develop antibodies to their own body and a protein called vinculin, and that creates autoimmunity. So CDTB toxin creates autoimmunity in animals, and we've translated that to humans now. But this slide shows that you get changes in the microbiome, more bacteria after the CDTB injection. You get more ileal bacteria, you get reduced vinculin expression, you get increased changes in stool weight, you get TNF changes and other cytokine changes just from being, this is all in the gut, this is in the gut wall. The rat got this CDTB in their arm, and now they have all these changes in the gut as a result of this immunization to this toxin. Let's talk a little bit about vinculin, because there's abstracts at DDW about vinculin and the antibodies to vinculin in humans with IBS. Vinculin is at the end of actin, at the end of the actin cytoskeleton, and it's meant to be a motor to drive cells out, to reach out to and grab onto each other. And nerve cells need this, especially nerve cells of the gut and interstitial cells, because they replicate, they grow, and they attach to each other. And if you don't have vinculin in knockout mice, you don't get an enteric nervous system at all. So having antibodies to vinculin could be a bad thing. So we think it's working like this. You expose yourself to CDTB, you get all these antibodies. We now know there's multiple epitopes on CDTB that create antibodies. One of them is similar to vinculin, and you get this autoimmunity. We now know the epitopes of CDTB that cause the autoimmunity to vinculin, and we now know the epitopes of vinculin to which autoimmunity occur, which is leading to sort of therapies that could be for the primary cause of IBS eventually. This is the main study that actually looked at using a blood test, anti-CDTB and anti-vinculin. This is almost 3,000 patients in this trial to see could these antibodies diagnose IBS? And the answer is yes, they diagnose IBS over IBD. So if you have two patients coming into your clinic and they have diarrhea, you do this test. If it's positive, I'll tell you what the result is. You have a 56% pre-test probability of IBS. If both are positive, it's now 95%. Medical certainty is over 80%. So you're now certain they have IBS. Now what does that do? Well, number one, if you did this test first, you may not do the colonoscopy or the other thing in the 25-year-old person because they're too young, and 90% of the time they don't, more than 90% of the time, they don't have an abnormal colonoscopy. You're doing too many colonoscopies in young people with IBS. And this could avert that. But more importantly, the patient now has a diagnosis. They feel confident that you were right, it's IBS, rather than relying on symptoms. And if it's negative, you're down to 24%. Another study, this is now the 5th worldwide, that shows that these antibodies actually diagnose IBS. This was a Mexican study where Mexico, food poisoning is very common in the indigenous population of Mexico. And they looked at a large cohort of 140 patients. And they found that, of course, the specificity of this test, the positive predictive value of this test is over 90%. But I want you to focus on the right, because that's the most important part, is that if both antibodies are positive, it highly predicted the benefit of rifaximin. If one antibody is positive, it also predicted the benefit of an antibiotic approach. And in that case, it was rifaximin in Mexico in this study. So the antibody was predicting this dysbiosis, this neuropathy of the gut that was leading to the dysbiosis. In this study, they took the CDTB antibodies, the vinculin antibodies, and just injected it into the animals. And the animals are alive, so they're using a fluoroscopic approach, sort of like looking for fluorescence from these antibodies, which are tagged. And on the left, you see that on the bottom, IgG, just general IgG, it goes everywhere. But if you inject the anti-CDTB antibodies or the anti-vinculin antibodies, they only go to the gut in vivo. And when you take the gut out, it only goes to the gut ex vivo also. So it's actually attracted to the elements of the gut. And then finally, in my 2 minutes left, there was 3 studies on fecal transplant at DDW for irritable bowel syndrome. So I'm going to highlight these. People have been asking me this question for years. I've always said it's going to be bad or it's not going to work, just based on what we see. Because if you have a neuropathy of the gut, you're accumulating bacteria. Why would you add more? And that was my philosophy. But these data may either prove me right or wrong. Let's go through it. So the aims of the first trial were to investigate whether fecal microbial transplant capsules, this was a capsule trial, versus placebo capsules would work in IBS. And the outcome measure was IBS symptom severity score. They were randomized 1-to-1 to fecal transplant or placebo. And they used 50 grams of stool from a healthy donor, and that's how they did the trial. And this is the result. So I want to just focus on the right-hand side. The left is just a description of the right. What we see here is there's absolutely no statistical difference between placebo and fecal transplant. But if you look more closely, what you see is placebo worked better than fecal transplant. So you could either think that placebo is a very good therapy for IBS, or you can think that fecal transplant overrode the placebo and made the patient worse. So there's 2 ways of looking at this data. So let's go to the next trial, but the conclusion is in this trial, fecal transplant did not induce significant symptom relief at 12 weeks compared to placebo, and then they did some subgroup analysis that maybe there's some subgroups that might be suggesting, although not statistically, benefit. Second trial, this is like a fecal transplant sandwich because this one worked. Okay, so to examine the effect of fecal transplant in IBS patients with severe abdominal bloating. So it's a little different than the other trial because these patients had severe abdominal bloating. Double-blind, single-center, placebo-controlled trial, refractory IBS with predominant bloating. Now, the donors they used in this trial were only two people that they did microbial analysis, and the microbiome in those two people had to be magically diverse. I don't know how I was going to say magically delicious, but that doesn't, magically diverse, and they used those two people only for the whole trial and then administered this. So, stacking the deck. And they showed that there was a benefit to fecal transplant here using, I'm going to go back because the outcome measure is very vague here. The primary endpoint was self-reported improvement of overall IBS and abdominal bloating. So it was very, very subjective. It wasn't using IBS-SS, which is a validated questionnaire. It was just, hey, how's your IBS doing? And there was some statistical significance there. So they're saying in patients with a lot of bloating, maybe it's going to be beneficial. And then the final trial is this trial from Denmark, and again, fecal transplant, 52 adults. It was again with capsules in this case, similar to the first trial in this sandwich of fecal transplant. And basically, I want to focus on the final line, which is underlined. IBS quality of life improved significantly in placebo more than fecal transplant. So once again, we're seeing perhaps fecal transplant is harmful or placebo is working better. So in conclusion, since I've gone a minute over time, the microbiome is important to IBS. We are understanding the origins of IBS based on the development of this concept of acute gastroenteritis precipitating IBS. Methane continues to grow as a concept in IBS-D, and there's probably 40 or 50 papers now substantiating methane and constipation. IBS-D and mixed are different because they are associated with these antibodies to CDTB and vinculin, whereas the IBS-C is not, and IBS-C appears to be associated with methane. FMT is not effective, and I put maybe harmful because of this comparator to placebo in the treatment of IBS. Thanks.
Thanks, Dr. Pimentel, for a great talk. Cynthia's going to do yet another computer swap, so we do have time for maybe a question or two.
Is there any effect on IBS from the experience of having extreme viral gastroenteritis? I mean, this is not relevant to the breath tests or the microbiota, but can that induce some kind of imbalance, or is this just a nothing event?
Least likely to precipitate IBS is viral, but the latest data was there was a paper in clinical gastroenterology that showed Giardia develops IBS, but Giardia has a tremendous amount of vinculin in that organism, and so the question is it the vinculin exposure, or is it the Giardia, or is it an immune response? We don't know, but there's a lot to learn, but at least we have some the pathophysiology starting to be worked out.
All set. Okay.